You're listening to Online Pet Health Podcasts with Dr. Megan Kelly. Continuing education for veterinarian rehabilitation therapists. Learn more at onlinepethealth.com.
Hey vet rehabbers, today we are chatting about arthrogenic muscle inhibition. Now it's going to be a real theory session today. Every month we do a research refresh in our paid membership, so I thought I'd give you the opportunity to listen to one of them. So this one's called Arthrogenic Muscle Inhibition Based Evidence, Mechanisms and Theory for Treating the Unseen in Clinical Rehabilitation. Now it's actually a human article, and the reason we chose this topic is that it came up in one of our lectures lectured by Gillian and Amy Hesbach. So it's often called AMI. And now I'm going to get this word wrong, and I've been practicing it so many times, but I'm going to give it a go. A neurophysical phenomenon where healthy muscle tissue is reflexively inhibited following injury to a joint. So if it's left untreated, it can really be a limiting factor in our outcomes, and it can impede our rehab goals. So before we head over to that research refresh, I just want to quickly tell you about our Facebook groups. If you're not a member, please come and join us online. This is where the vet rehabbers hang out online. They share research, tips and advice, and it's a great supportive community. We'd love to have you online there with us. We have 4 groups: the small animal vet rehabbers, the hydro vet rehabbers, equine vet rehabbers, and our business vet rehabbers. So, are you ready to learn more about AMI? So this training was done by Lloyd from the Onlinepethealth team.
Good morning, vet rehabbers. I hope that you are all doing really well today. Today's article is on arthrogenic muscle inhibition, the best evidence, mechanisms and theory for treating the unseen in clinical rehabilitation. And it was published in 2021. The reason I wanted to go through this article, this is a human-based paper, but the reason I wanted to go through it is because of AMI being mentioned in a recent series that we did with Gillian and Amy Hesbach on neurodynamics. And this AMI is a component of that breakdown of the nervous system that results in dysfunction within our musculoskeletal system that not all of us are aware of within our patients. So let's dive right into this article. On humans, I'm going to try and only kind of take out what's relevant for us as animal rehab practitioners, and we go from there. Right, so AMI, or arthrogenic muscle inhibition, occurs following a joint injury or an orthopedic condition and results in inhibited muscle function and activation. If it's left untreated, it can be a major limiting factor in the success of a rehabilitation program. So AMI occurs secondarily to joint injury and results in a reflexive inhibition of muscle activation. Inhibition occurs within the motor neuron pool as well as the central nervous system. So we have a peripheral and a central component to the inhibition that's occurring. During the acute phase of healing, cryotherapy, TENS, NMES are all modalities that can help reverse inhibition or disinhibit. And then during the subacute phases of healing, we can use things like eccentric exercises and vibration therapy to aid in reversing inhibition or to disinhibit. So AMI is a neurophysical phenomena in which healthy muscle tissue becomes reflexively inhibited following an injury to the joint. It can occur as a result of injury in any joint and can significantly impede the recovery of muscle function and ultimately rehabilitation of our patients. As early as 1965, it was established that stretching of the joint capsule as a result of effusion led to a reflexive inhibition of the surrounding muscles. In the 1980s, this was confirmed and further established that the degree of inhibition was related to the degree of effusion within the joint. Pain may or may not be present in a joint for AMI to occur. In the 2000s, the role of AMI and its treatment became more popularized, and studies were conducted to try and identify interventions that could successfully treat AMI. To appreciate the broader impact of AMI, we need to consider the clinical manifestations and how they influence the interactions between the patient, their functional activities, and their environment. In patients experiencing AMI following joint injury, surgery, or pathology, we will see muscle weakness, reduced muscle activation or failure to activate muscle, and muscle atrophy over time. So these are all things that we see every time we see a cruciate patient with hip dysplasia, elbow dysplasia, anything where the joint is involved, we see reduced muscle activation. IVDD is a good one, kissing spines. In all of these instances, we have muscle weakness, reduced muscle activation, and over time muscle atrophy. Muscle function is dependent on the availability of motor neurons within the muscle, as well as the ability to voluntarily recruit them. So patients with joint injury usually present with fewer motor neurons available for recruitment or a lower motor neuron pool excitability, as well as a reduced ability to voluntarily recruit motor neurons or central activation failure, so peripherally and centrally. This inhibition is reflexive and involuntary and is controlled by the presynaptic mechanisms within the spinal cord or a lowered spinal reflexive excitability during acute stages of healing as a result of tissue damage, joint laxity, joint effusion, pain, or inflammation within a joint. Changes within a joint disrupt the normal neural signaling between the joint receptors and the central nervous system, changing the sensory feedback transmitted to the spinal cord and the brain. Clinical interventions or modalities that help to restore or augment the sensory information should be incorporated during the acute phase of healing. Within the human population, persistent muscle impairments are commonly reported at the end of rehabilitation periods, when patients are returning to unrestricted activity, and this can last for years following an injury and can contribute to high re-injury rates and further dysfunction. I've experienced this firsthand with an ankle injury or an ankle fracture when I was young. It took many years for the function of my ankle to be equivalent to or equal to the opposite ankle, the other ankle, despite me doing a lot of exercise and work to help rehabilitate it. So what does and doesn't change over time? Firstly, the motor neuron pool excitability resolves over time. Okay, so our motor neurons become available again as time passes. Central activation failure does not resolve without intervention. So what happens on the spinal cord level and the brain level, that doesn't change unless we intervene. During chronic phases of healing, a decrease in corticospinal excitability occurs. So there's a silencing in the cortical map. A difference in brain activity indicates functional activities require greater cognitive effort, attention, and visual support in the long run. So while in the acute phase of injury, the cause of muscle inhibition is primarily caused by injury to the joint. Over time, it will shift to primarily being caused by a corticospinal mechanism. A failure to address AMI in the initial phases of healing may result in maladaptive neuroplasticity and lead to persistent muscular impairments and compensatory movement patterns. Okay, so here we have a table where they explain this from the paper. So the gray circle is our motor neuron pool. The yellow circle is the available motor neurons to actually perform a function, and then the green circle is the recruited motor neurons. Okay, so what can actually be recruited. So this is what a normal muscle would look like, right? In the acute phase after an injury or surgery or whatever might happen to a joint, we see that the motor neuron pool is the same, but the available motor neurons is much less, and recruited motor neurons are even less. So we see less availability, less recruitment, and theoretically or hypothetically no variability in that availability. And clinically, we have weakness, muscle inhibition, and poor motor control in that acute phase. So over the course of rehabilitation, 6 months later, all right, it looks like this. So we have the same motor neuron pool. We have more motor neurons available, so our availability has returned to the normal amount, but we still have a lower recruitment, motor neuron recruitment. So many available, less recruited, and low variability in theory. So we have a weak but functional muscle. The muscle is still inhibited. There's decreased motor control, and there's a compensation system that's occurring. And so that compensation is important for us to consider with our patients. How are they adapting to the lack of recruitment or force that they can generate with this specific muscle? And then at the return to sport phase, we see basically the same thing, with low variability under high demand, leading to exhaustion of compensation system. And here we have a high risk of injury. So unless we return we need to have a higher availability of motor neurons. Sasha, guys? We need to have a higher availability of muscle neurons to allow us to return to sport, or our patients, and to reduce the risk of injury. We need to make sure that whatever compensation strategies are implemented are going to actually be helpful. So I would recommend that to learn more about neurodynamics and the changes that occur to the peripheral and central nervous system, because remember, at this point, our inhibition is coming from the central nervous system and the cortical map. I would recommend watching the series. There's one in the small animal and one in the equine members portal by Amy Hesbach, where she discusses neurodynamics in depth. So in terms of interventions, the use of any modality or clinical intervention must be linked to a specific goal and needs to be safe and effective at the specific point of healing in which it is utilized. The individual needs of the patient must always be considered when developing a treatment program. So in this table, we can see multiple interventions, treatment interventions, modalities, from cryotherapy, TENS, eccentric cross-exercise, ultrasound, NMES, and they've blocked here what it's proven to do. So what is the supported literature regarding that specific point? So focal joint cooling in terms of neural excitability, yes, that's supported. In terms of morphology, not supported. In terms of muscle activation and strength, supported. Neural excitability on a cortical level, not supported. Neurocognition, not supported for cryotherapy. And so it goes through each modality and the evidence that we have for it. So this is very valuable if you're wanting to look at a specific modality, and where to use it, when to use it as well is very important. So let's go through the individual modalities and see what we come up with. So first of all, during the acute phase of healing, we basically have 3 goals or 3 areas of focus. We want to minimize pain, swelling, and inflammation. We want to improve muscle function, and we want to minimize muscle atrophy. So in terms of focal joint cooling or cryotherapy, during focal joint cooling, we may reduce AMI by altering the sensory input from nociceptors and thermoreceptors, as well as increasing the motor neuron pool excitability and the voluntary activation of muscles. To achieve focal joint cooling, cryotherapy needs to be applied around the entire affected joint for 20 to 30 minutes prior to therapeutic exercise. Cryo may provide a 60-minute treatment window where there is an increased availability of motor neurons, making this modality ideal in the rehabilitation setting prior to therapeutic exercise. It's commonly used to address and reduce pain perception, thus disinhibiting or masking the initial signals originating from the joint. According to this article, the clinical bottom line is focal joint cooling has the potential to increase motor neuron pool excitability and voluntary activation among individuals with lower extremity joint injury. The effects appear to last the duration of a traditional rehabilitation session. Application is most appropriate to apply prior to exercise. Looking at TENS, transcutaneous electrical nerve stimulation, TENS may reduce inhibition by masking the inhibitory signals of AMI. When positioned over a joint, high-frequency TENS masks type 1 and 2 afferent fibers responsible for presynaptic spinal level reflex mechanisms and subsequent inhibition of motor neurons. High-frequency TENS of 120 to 150 Hz has the greatest disinhibitory effect for increasing voluntary muscle activation when compared to other modalities. TENS can effectively increase muscle activation and maximal voluntary contractions. The most pronounced effects can be achieved when TENS is applied for more than 20 minutes prior to exercise following surgery or joint effusion. TENS can create a 45-minute therapeutic window where motor unit excitability and strength are temporarily restored, making it the ideal modality to use during therapy prior to therapeutic exercise. So the clinical bottom line, according to this article, is that high-frequency TENS applied before and or during exercise can increase the availability and voluntary recruitment of quadriceps motor neurons in those with quadriceps inhibition. Taking advantage of this therapeutic effect results in retention of gains over 4-week training periods, although effects may not be better than exercise alone. NMES, or neuromuscular electrical stim, NMES circumvents inhibited motor neurons through direct stimulation of the muscle, thereby supporting muscle strengthening and preventing atrophy during periods of AMI. When NMES is used during exercise, it may help retain the motor neuron recruitment and improve force production. NMES can be paired with eccentric exercise to improve strength and voluntary muscle contraction. It can also be paired with isometric exercise to improve motor neuron pool excitability. So quite exciting, those points. The clinical bottom line, the use of NMES in conjunction with therapeutic exercise may help minimize strength and muscle volume loss in early phases of recovery and improve voluntary recruitment of motor neurons. The use of NMES may be the most beneficial during the early phases of recovery, but may become less effective as patients' strength and voluntary muscle activation is restored. Nonthermal ultrasound. The acoustic energy produced by therapeutic ultrasound may deliver mechanical stimulation to the joint receptors implicated in AMI and is safe to use in the acute phases of healing. Low-intensity nonthermal ultrasound has been shown to increase motor neuron pool excitability 20 minutes after treatment in one study. Theoretically, ultrasound may mask inhibitory signals from the injured joint, supplement sensory input, facilitate a muscle response. This modality does, however, warrant further investigation. Clinical bottom line, very limited evidence suggests that non-thermal ultrasound has the potential to disinhibit quadriceps motor neurons via spinal reflexive excitation. Theoretically, application prior to therapeutic exercise may induce an open and exploit effect. So, clinical bottom line, this would not be my go-to modality. Eccentric cross exercise. Eccentric cross exercise involves exercising the contralateral limb to increase strength in the ipsilateral limb by leveraging a neurological crossover of information between brain hemispheres. Eccentric cross exercise produces greater strength and neural activity when compared to concentric exercise. Eccentric cross exercise interventions can reduce intracortical inhibition, increase cortical drive to the untrained muscles from spinal and paraspinal motor pathways, improve motor neuron pool excitability, corticospinal excitability, motor cortex activation, improve strength, and reduce muscle atrophy. Clinical bottom line, by leveraging the uninjured contralateral limb, eccentric cross exercise can enhance strength and neuromuscular control following joint injury through supraspinal mechanisms. Since traditional eccentric exercise is typically contraindicated in the early phase of recovery, training the uninjured limb may increase communication between the motor cortices and translate clinically as improved muscle function. Yes, potentially. So during the subacute recovery phase, our treatment goals shift from treating pain, inflammation, and diffusion to increasing joint load and strengthening of the muscle. Persistent AMI will delay these goals or lead to compensatory movement patterns during functional activity of the patient. Therefore, treating AMI during this phase could include modalities such as eccentric exercise, vibration, and antagonist fatigue. So eccentric exercise. Eccentric exercise increases the morphologic and neurological characteristics of muscle function while increasing muscle strength, activation, and hypertrophy. While eccentric exercise is an effective way to restore muscle function and volume following injury, its translation to functional movement remains unclear. Eccentric training produces greater force production than concentric resistance training, as it maintains actin and myosin cross bridges and increases the excitation of the supraspinal pathways, increasing the cortical activation and signaling to peripheral musculature and increasing voluntary motor neuron recruitment. The clinical bottom line is that in conjunction with traditional rehabilitation, eccentric-based exercise should be used to help restore muscle strength, voluntary activation, and volume after traumatic joint injury. Vibration. Vibration therapy may reduce the effects of AMI by altering the somatosensory input to articular and cutaneous mechanoreceptors. Following orthopedic injury, both whole body vibration and local vibration have been shown to enhance aspects of muscle function in individuals with joint effusion, arthritis, joint pain, chronic joint instability. Within human medicine, vibration is usually applied in short bouts of 30 to 60 seconds, either through a whole body platform or directly to a muscle tendon unit during therapeutic exercise with a handheld device. Vibration therapy is thought to provide a 60-minute window where voluntary motor neuron recruitment is enhanced in previously inhibited motor neurons. Strength gains, this is important, strength gains following a training regimen that included vibration therapy appear to last longer than strength gains from therapeutic exercise alone. And that was over, they looked at that, those strength gains up to 9 months after therapy, after the exercise regimen. So that's quite significant. The clinical bottom line is that vibration therapy applied in conjunction with exercise or static muscle contraction has the potential to enhance muscle function more than control conditions, allowing for a sufficient therapeutic window. Vibration appears to be appropriate for use once the patient can adequately load the injured limb and has regained enough neuromuscular control to perform repeated or prolonged muscle contractions. So within our rehabilitation practices, working with someone who has a TheraPlate in the equine industry, or working with a whole body vibration platform in small animals can really be valuable for these reasons. Okay, antagonist fatigue. This is quite an interesting one, which was new to me for sure. So antagonist fatigue exercise is a novel, clinically relevant intervention that may improve muscular impairment resulting from reciprocal inhibition. After a joint injury, the antagonist muscle may be facilitated by supraspinal influences to stabilize the joint and prevent further damage to the intra-articular tissue. Fatiguing the antagonist muscle may therefore improve neuromuscular function of the agonist by reducing neural drive to the antagonist and mediating co-activation after injury, decreasing motor neuron firing rates and recruitment from the antagonist motor neuron pool, allowing for greater activation of the agonist and reduced co-activation and enhanced agonist muscle function. So how would we apply this antagonist fatigue in our patients? I can't think of clinically applicable exercises to use to specifically fatigue one muscle other than to inhibit the antagonist and to facilitate the agonist through kinesiology taping prior to exercise. Okay, so that's my thought, but let me know if you guys have other ideas of how we might achieve this and work with this. The clinical bottom line in this paper is that antagonist fatigue may serve to reduce antagonist-agonist co-activation. Reducing the facilitation of the antagonist muscle leverages reciprocal inhibition and allows for more optimal agonist muscle training. In the chronic recovery phase, so as the joint health is restored and the functional capacity of the patient improves, our clinical goals will again shift towards achieving long-term joint health and a return to sport or competition. During this phase of recovery, we'll focus on improving neurocognitive function and redeveloping motor skills and integrating the patient back into competition. So I want to just for a moment come back to this initial image so that we have that in our minds. So if we're coming into this chronic recovery phase over here, okay, we are primarily dealing with, we have the local, available motor neurons. What we lack is the corticospinal input to be able to use and utilize them. So we have to be training the brain in this part of rehab. Dun, dun, dun. And then I've gone too far. Okay. So in the article, there are quite a few experimental and emerging interventions that are discussed. Many of them are not relevant within our field. So I'll only discuss motor skill training and neurocognitive training. And even so, I would actually like to refer you to Ansie van der Waldt's lectures where she speaks about, there is one in the small animal and one in the hydro platform, where she speaks about taking advantage of the cognitive aspect and how we can train the brain during therapeutic exercise. They're both brilliant lectures, so if you want to really focus on this phase of recovery, then that would be my recommendation. But in short, motor skill training involves retention and transfer of motor skills to be promoted by prioritizing implicit learning and feedback, promoting differential learning by manipulating the environment, utilizing random practice schedules, and ensuring patient motivation and autonomy. Skill retention and transfer over time can be improved by adding variability to the task and the environment and performing random practice. So that thing that we do where we like to do 5 repetitions of one exercise and then go to the next exercise and do X reps and cycle them around, that stops, and we randomize the exercise we do, the movements we perform, and we have like a level of reactivity in our patient where they need to be paying attention to see what comes next. Varying the environment is a big part of that. So I hope you can hear the bird that's in the tree here next to me. Okay, so variability in the environment is very important in this phase as well. We want to change environment, surfaces, as much as we can. We want to be manipulating, changing, adding, etc., so that we're really getting that cognitive input from the patient. Clinical bottom line, The principles of motor learning should be applied to address neural plasticity, underlying motor impairments induced by joint injury. Great. Cognitive training, neurocognitive training. So neurocognitive training may prepare the patient to return to uncontrolled athletic environments where cognitive demands are increased. This includes dual task performance, reaction time, visual attention, and self-monitoring. Poor or prolonged cognitive processing in an uncontrolled environment may put the patient in greater risk of re-injury. Okay, so for us, I want to say that, horses that are being turned out into a paddock with other horses are going to be in an uncontrolled environment. And if we do not address their cognitive processing, then they will be at risk of re-injury just in that environment. If we add a competitive environment to that as well, we're increasing that risk. So dual task training is commonly implemented in rehabilitation in patients with a history of neurological impairment, as well as in the elderly, to improve postural stability. So again, not only relevant to athletes, it is actually relevant to every patient that walks through our doors. If we think of dogs, they go home into an uncontrolled environment. They are running through the house, slipping on the floors every time the doorbell rings. When they go for walks or hikes or whatever the case may be, they are in an uncontrolled environment where they need to have good cognitive processing to prevent re-injury or to ensure that they are at their best to prevent any injury. So yes, again, I would refer you guys to Ansie van der Wald's webinars in this, because she discusses these aspects in great detail and how we implement them into practice. So in conclusion, AMI contributes to muscle weakness, activation failure, and atrophy in patients recovering from joint injury or surgery. Without a return to normal muscle function and activation, rehabilitation outcomes will remain poor, and the patient will maintain a high risk of re-injury or secondary injury and dysfunction due to compensation. During the acute and the subacute phases of healing and rehabilitation from joint injury, it's essential that AMI be considered and treated with effective and evidence-based methods. AMI intervention should always be patient-specific and should focus on treating and resolving pain, inflammation, and edema as soon as possible. And with that, I want to say thank you to the authors who put this together. I want to say thank you to Amy and Gillian Tabor for opening the doors to these subjects, these neuroplastic areas that we need to better understand from a scientific perspective, to be able to effectively address all the needs of our patient. And so with that, I will leave you guys. Thank you for your attention and for your time today. I hope this has been valuable. Please chat to me, let me know what you think, and have a great day.
If you enjoyed this podcast, please hit the subscribe button so you get notified every time I load a new podcast. I'm here every week talking to vet rehab therapists from all over the world about all things vet rehab. Don't forget to bookmark the next Vet Rehab Summit on Saturday, the 4th of November. Come and be a part of the world's largest online veterinary rehabilitation conference created specifically for you, the vet rehabber community. Onlinepethealth members get VIP complimentary access to the Vet Rehab Summit. For more information about continuing education for vet rehabbers, you can go to onlinepethealth.com.